Medical records. Medical records, health record, medical chart are the document that explains all detail about the patient's history, clinical findings, diagnostic test results, pre- and post-operative care, patient's progress, and medication. If written correctly, notes will support the doctor about the correctness of treatment. A medical record includes a variety of types of notes entered over time by healthcare professionals, recording observations and administration of drugs and therapies, orders for the administration of drugs and therapies, test results, X-rays, reports, etc. Why medical records are important. Monitoring of the actual patient. Medical research. Medical education. For insurance cases, personal injury suits, workmen's compensation case, criminal cases, and will cases. For malpractice suits. For medical audit and statistical studies. Electronic health records. An electronic health record, ER, is an electronic version of a patient's medical history, that is maintained by the provider over time, and may include all of the key administrative clinical data relevant to that person's care under a particular provider, including demographics, progress notes, problems, medications, vital signs, past medical history, immunizations, laboratory data, and radiology reports. Component of medical records. Patient identification, patient registration form. Consent for treatment, evidence of appropriate informed consent. Patient medical history including drug allergies. Medication sheet. Problem list. Physical examination and system review in the encounter. Diagnostic and therapeutic orders. Clinical observations, including progress notes, consultation reports, nursing notes, and entries by specified personnel. Laboratory reports, reports of tests and their results. Reports of procedures and their results. Conclusion if terminating treatment. Condition at discharge, medications prescribed, and any instructions for follow-up care. Immunization records. Arrival time. Mode of transport. Preventive medicine services. Preventive medicine screenings. Invasive procedure consent, if applicable. Medicare lifetime claim authorization, if applicable. Waiver of Medicare liability, if applicable. ABC Hospital. 7G, Rainbow Colony, Ananagar 1st Street, Chennai 28. Emergency Department Report. Demographic data. Patient, James Robert A. Dobb, August 3, 1955. Age, 62. Sex, male. MRN, XXX000123. Account, ABC 00012345. Service date, July 12, 2021. Arrival time, 12:10 p.m. Mode of arrive, ambulance. Report type, ETOH, registered physical therapist. Report status, signed. Report mnemonic, phy.er. Time seen by MD, 12:13 p.m. Chief complaint, alcohol abuse and SI. History of present illness, HPI 62-year male who is obviously quite intoxicated upon exam presenting to the ED with complaints of alcohol abuse and SI. The patient states that he has been drinking over 45-ounce bottles of beer. He states he cannot get up and around due to motivational issues. He reports that he is dying of alcohol poisoning. The patient states that he had SI. He denies any plans but states that he has had previous attempts involving inflicting wounds upon himself with a knife and attempted to overdose on Valium. He denies drug use. Past medical history. Allergies, no known allergies, unverified, September 12, 2020. Home medications. Hydroxyzine 50 mg capsule 1 tab po daily total 30. Aripiprazole 2 mg tablet 1 tab po daily total 30. Past history, HTN. GERD. Past surgery, appendectomy, August 8, 2019. Family history, DM. Social history. Substance, ETOH, alcohol. Marital status, divorced. Travel history, travel and/or hospitalization outside the U.S. in the last 30 days, yes. Review of systems. Constitutional, no symptoms reported. Eye, no blurred vision, no double vision. And, no symptoms reported. Respiratory, no symptoms reported. Cardiovascular, no symptoms reported. Gastrointestinal, no abdominal pain, no diarrhea, no nausea, no vomiting. GU, no symptoms reported. Musculoskeletal, no back pain. Skin, no symptoms reported. Neurological, no dizziness, no headache. Psychological, alcohol abuse, suicidal ideation. Endocrine, no symptoms reported. Hematologic/lymphatic, no symptoms reported. All other systems reviewed, negative. Physical exam. Vital, temp, 97.3. Pulse, 74. RESP, 18. B/P, 155/94. Pulse ox, 93. O2 delivery, room air. General examination, patient on the bed not in acute distress. Hint examination, atraumatic, normocephalic, PERLA, EOMI. Neck, no JVD, no signs of trauma, no tenderness on palpation. Cardiovascular, S1 S2 regular rate and rhythm. Respiratory, clear to auscultation bilaterally, no wheezes or crackles. Abdomen, soft, non-tender, non-distended, positive bowel sounds. Psych, positive SI, negative plan. Extremities, no tenderness on palpation, no edema. Neuro, grossly intact. Skin, no rashes or lesions. Physician order. Laboratory tests. Normal saline 1000 ml at 1000 ml/hr. ECG. Medications administered. Medications, sodium chloride, normal saline. Dose, 1000 ml at 1000 ml/hr. Start time, July 12, 21, 12:28. Stop time, July 12, 21, 12:40. Laboratory tests. POC glucose 116 mg/dl, 65 to 110, H. Eosinophils, 2.1%. Hematocrit, 47.6%, 42.0 to 52.0. Urine opiates screen, none detected. Urine phencyclidine screen, none detected. Urine tricyclic antidepressants, none detected. Diagnostics and interpretation. ECG interpretation by Ed MD. Normal sinus rhythm, 88 BPM, normal axis, no ST elevations or depressions on my reading. Medical decision making. Differential diagnosis considered but not limited to acute depression, suicidal ideation, homicidal ideation, drug abuse, ETOH abuse, paranoia, schizophrenia, hallucinations. Patient treated with 4 fluids, and after getting 4 fluids and is staying here in emergency room for some time, he became sober and denied any suicidal ideation afterwards. I consulted psychiatry department and they came and evaluated the patient and agree the patient is not suicidal, and they gave him outpatient referrals. I talked to the patient/family in detail about the studies done in the emergency room, diagnosis, and importance of following up with the primary care physician on the outpatient basis as soon as possible, and they agree with the plan. Impression. Primary impression, acute depression. Additional impression, ETOH abuse. Condition, stable. Disposition, discharge home. Additional instructions. Diagnosis, expected course, potential complications, and medications discussed with the patient. Patient instructed to follow up with primary care physician in 1 to 2 days and immediately return to the emergency room if symptoms worsen. Patient verbalizes understanding and willingness to comply. Attestation. Scribe attestation, documentation prepared by, medical scribe listed below. I. MSEHPI/exam. Pre-Ianka, CHA prescribed December 8, 2021, 12:35. Irfan Khan December 8, 2021, 12:40. This is not considered final until signed by a physician. Authenticated by, December 8, 2012. Professional Coding ICD. PDX, F32.9. SDX, F10.10. Explanation. Impression, acute depression. ETOH abuse. Index. Depression, acute, mental, F32.9. Abuse. Alcohol, non-dependent, F10.10. Professional Coding CPTs, 99,283. 93,010 99,053. CPT 99,283 Emergency Department visit for the evaluation and management of a patient, which requires these 3 key components: an expanded problem-focused history, an expanded problem-focused examination, and medical decision-making of moderate complexity. CPT 93,010, electrocardiogram, routine ECG with at least 12 leads, interpretation and report only. Arrival time, 12:10 p.m. CPT 99,053. Service or services provided in addition to basic service between 10 p.m. and 8 a.m. at a 24-hour facility. Facility coding, 93,005. A0429. CPT 93,005, ECG tracing only. CPT A0429, ambulance service, basic life support, emergency transport, BLS emergency. Mode of arrive, ambulance. Medications, sodium chloride, normal saline. Dose, 1000 ml at 1000 ml/hr. Start time, July 12, 21, 12:28. Stop time, July 12, 21, 12:40. Don't code 96,360 intravenous infusion, hydration, initial, 31 minutes to 1 hour. Reason, 40-28 equals 12 minutes. Not met minimum of 31 minutes.